Thank you for joining Family Caregiver Alliance for 10 Things You Need to Know About Hospice. For over 4 decades, Family Caregiver Alliance has been working across the Bay Area and the nation to improve the well-being of family caregivers. We offer support through consultations, classes, workshops, publications, research, and advocacy. If you'd like to learn more about us or access our online resource center, CareNav, please visit us at caregiver.org. Now, during the webinar, your phones or mics are going to be muted, so if you have any questions, you can ask them by using the Zoom Q&A box, and we will answer as many questions as we can at the end of the webinar. Also, at the end of the webinar, I'll be asking for a little bit of feedback, and I'd certainly appreciate if you could let us know how we did. And now I'd like to welcome our presenter, Helen Bauer. Helen has been a nurse for over 30 years, specializing in hospice and end-of-life care for the last 15 years. Her passion for quality end-of-life care is heard on the Heart of Hospice podcast in discussions on end-of-life care, hospice philosophy, advanced care planning, and grief. As owner of Hospice Navigation Services, she provides support for anyone needing information about hospice and end-of-life care. You can find the Heart of Hospice podcast and Hospice Navigation Services at our website, theheartofhospice.com. And I'd like to turn it over to Helen.
Hi, everybody. Thank you, Calvin, and thank you to the Family Caregiver Alliance. It's great to be with you today. And thanks, Calvin, for partnering with me for today's presentation. I want to say thank you also to everybody who's attending today because and anyone who'll be watching it in the future, because if you're a caregiver, your time is precious. And I hope the information we go over today give you things that help you on your caregiving journey and make things just a little bit easier for you. So we're going to jump right in. We've got a few goals for today. My hope is that you'll be learning some of the basics of hospice philosophy, that you'll get an idea of when you should consider hospice, whether it's for yourself or for a person that you care about, your person. I hope that you will be able to identify the core members of the interdisciplinary team, the hospice team, and what they do for a hospice patient. My goal is also to help you learn who can make a referral to hospice, who can get that hospice care started. And I also hope that you have an understanding of who can start it and who can stop hospice care. All right, so my first thing that I have listed that you should know is hospice is a type of healthcare. There's confusion around this. There's a lot of confusion around hospice in general, but this is kind of a big one. So hospice is not a place, it's a type of healthcare. It's a type of healthcare that's given to people when they're nearing the end of life. Hospice is intended for someone that has a limited life expectancy, 6 months or less. It's also called a terminal diagnosis. That's a term that we use in healthcare. Hospice care focuses on comfort, on managing symptoms, making the patient comfortable, and on promoting their quality of life. And quality of life is whatever that means to the person who is on hospice. One of the unique things about hospice care is the care includes support for the caregiver, for the family. I include family and non-family caregivers in this group because not every caregiver is a family caregiver. Not every person who is on hospice has family support nearby who are willing and capable of providing care. So tips in this area, some tips that you should know, is that while the hospice criteria is a life expectancy of 6 months or less, many patients live beyond that 6 months and much longer. The hospice care gets extended by the agency for as long as the patient still qualifies. One myth that's out there about hospice is that when the hospice care starts, the person immediately goes to a hospice place. There are hospice facilities and hospice houses, but they're not available everywhere, especially rural areas. There is specific medical criteria and sometimes financial criteria for using those facilities. Most of the care of hospice patients takes place in their own homes, including a private residence, nursing homes, assisted livings, halfway houses, and even homeless shelters or shelters for the unhoused. As caregivers, it's important for you to know that hospice staff never takes the place of the family caregiver. We're not staffed to be with patients for unlimited hours day after day. The day-to-day care of a hospice patient who is stable always falls to the family or the caregivers in the home or to the facility staff. Hospice never takes the place of family caregivers. All right, item number 2. Hospice includes palliative care, but it's not the same as palliative care. This is such a confusing subject, even for people who are working in healthcare. So palliative care is a specialty, just like oncology is cancer care, excuse me, or nephrology is care for the kidneys. Palliative care is a specialty. It supports symptom management and quality of life, similar to the way we do in hospice. But palliative care is provided at the same time that a person is receiving curative or aggressive care, is receiving treatment. So not all palliative care includes hospice. However, all hospice includes palliative care, always. When someone is on hospice, they are receiving end-of-life care, including palliative care, but they are no longer receiving curative or aggressive treatment. So that's the difference there. So a few tips to go with this information. Hospice is always about comfort, always. That means different things to different people. The patient gets to decide what comfort is to them and what quality of life means for them. And caregiver support is always part of hospice care. The patient is at the center of everything we do, and care for the family or the caregivers is included. All right, item number 3. Item number 3 is about how the hospice team is set up. And I'd like to spend a few minutes really diving deeper into this to talk about the members of the team and what they do for the patient. There are 4 core members of the hospice team, and each of those members plays a specific role. The team includes clinicians and other end-of-life workers. Each team member brings their special skills, their special training to the care of the patient and support of the caregiver. We care for the whole person, body, mind, and spirit. One of the 4 team members that's a core team member is the physician or the hospice medical director. They give orders for medications, wound care, treatments or procedures that are needed, and help coordinate with the nurse that's on the team about what the patient needs. The nurse coordinates the care of the patient, communicates really closely with the hospice physician and the other team members, and also can coordinate with the patient's attending physician, who might be their primary care physician who has stayed on as part of their care under hospice. The nurse also helps to provide symptom management, does procedures and treatments that the physician orders, but most of the work that a nurse does for a hospice patient is education about death and dying and end-of-life care and what's happening. The third member of the core part of the hospice team is a spiritual counselor, or chaplain, as they're more widely known. The chaplain provides spiritual support according to whatever the patient or the caregiver believe. They coordinate with local clergy if the patient and family requests. They also counsel about spiritual or religious or existential issues according to what the patient needs. And the chaplain can provide grief counseling as well. When it comes to the role and the work of the chaplain, it's really important to understand that the personal Faith beliefs or religious beliefs of the chaplain do not come into play here. The care of the hospice patient from the chaplain is all based on the patient and the caregiver's faith beliefs. So regardless of religion or non-religion, the chaplain provides care that does not include converting, saving, redeeming, proselytizing. It's all about meeting the patient and the caregiver where they are in their particular spiritual beliefs. Social workers are the fourth member of the core team. They're the problem solvers of the hospice team. These are our go-getters. These are the people we go to when we need help and we don't know the answers. They work to ensure that the patient is safe and that the caregiver is willing and able to provide the care. They offer respite and coordinate that when a caregiver gets overwhelmed. They offer other resources that are needed. They also help with finding benefits that the patient is entitled to. They assist with funeral planning, and they also do family conferences and grief counseling as well. One of the special things I wanted to highlight about what social workers and chaplains do is legacy projects. These are really special projects or activities that recognize the memories and life of the person who's dying. They're a really special part of hospice care. Legacy project can take on a lot of different forms, everything from photo and storybooks to letters to loved ones, or even the creation of a nonprofit foundation if that's something the patient wants to do. So you can see that the social workers and chaplains have a lot of different roles. They wear a lot of different hats, but they are such a vital part of the team. Other members of the team include our hospice aides, nursing assistants, or CNAs. They are essential people on the team. They provide personal care for our patients, everything from standby assist to for a shower to a full bed bath for someone who is bedbound and incontinent. They're responsible for not just cleaning the patient and turning them and changing the bed sheets, but they monitor the skin and they report any changes or issues to the nurse so that the team functions as a big group. Nurse practitioners are also utilized by some hospice agencies, not all, but sometimes they are required to do in-home visits that are mandated by Medicare. And that ensures that the patient continues to meet the criteria for hospice care. Our nurse practitioners work very closely with the hospice physician. Therapies. Now, there is a lot of confusion around how certain therapies are used in hospice. The main clinical therapies, physical therapy, occupational therapy, and speech therapy, are used very sparingly in hospice and only with the goal of improving quality of life for the patient, keeping the caregiver safe, or enhancing comfort for the patient. Other therapy modalities like massage therapy, music therapy, aromatherapy, pet therapy, those are used for comfort, companionship, and enhancing quality of life. As a caregiver, you should know that while music and massage and pet therapy aren't provided by every agency, every single hospice agency in the US is required to have access to the three clinical therapies, PT, ST, and OT. Dietitians are also a part of a hospice team. They provide nutritional guidance when there's a very specific need for that. Again, they're used very infrequently in the care of a hospice patient. And then our volunteers. They're a really special part of the hospice interdisciplinary team. These folks are out seeing patients, providing companionship, supporting caregivers, all in the communities where they live. They often become close to the families that they care for and make visits with. Many of these volunteers have been caregivers themselves, often for someone who's been on hospice and has died. And so these volunteers know what it's like to have a loved one on hospice. They're a really special part of the hospice team. So here are a few tips I want you to know about the hospice team. It's challenging as a caregiver to allow all these people to come into your home, to your private space at a time when your loved one is sick. You might be worried, you're exhausted, you're stressed, you might be experiencing financial issues. So I would ask you to keep an open mind about having a team member and allowing them to provide care to you and your person. Try to keep an open mind. If you're not clear on what exactly that team member does, give them a chance to show you. They might bring something to your care that you didn't even know you needed. And you don't have to use all the members of the team. Maybe your faith life or your spiritual beliefs are very private to you. Or maybe you'd prefer to work with a clergy person that you've known for many, many years. You can choose to do that and not have the chaplain visits. Or maybe at this point in your person's illness, you're managing their personal care just fine. Or maybe they don't even need any help with their personal care, they're bathing. The aide or any of the team members can be added at a later date if things change and you decide you need them. All you have to do is ask. Okay, item number 4. You can start the conversation about hospice care. And I love this particular one because it's so empowering. You don't have to wait for anyone else to bring up the topic of hospice. It doesn't mean your care has to change. It doesn't mean the treatment is stopping. It's just a way of getting information. Talking about it before there's a need or an urgent need, makes it so much easier for you and your person to process later on. You don't need an order from a doctor. You don't have to have a referral to talk to a hospice agency. You, as a caregiver, can talk to any hospice agency you want. The doctor doesn't get involved until you need the care to start, because hospice care requires a doctor's order to get going. Conversations about end-of-life care are really difficult, but they make a lot of things possible. When the caregiver knows what their person wants, the decisions are easier. And the grief journey as a caregiver is actually a little bit easier too. So here's some additional tips about these end-of-life conversations and end-of-life issues about death and dying. Give yourself some grace. Allow yourself to feel the way you feel and do the same for others. These conversations are difficult and you are doing something hard. Grief is part of the package when it comes to end of life. And that means there's a big mixed jumbled bag of emotions. Every emotion, guilt, fear, sadness, anger, resentment. Sometimes there's even a sense of relief that comes with having these conversations, acknowledging that big elephant in the room and voicing feelings and thoughts that you haven't been able to share or your person hasn't been able to share. So keep that in mind when you're having these conversations. All right, item number 5. The decision about starting and stopping hospice lies with the person with the life-limiting illness or with their caregiver or decision maker. A doctor decides whether the patient qualifies and provides the order for hospice care. The patient or decision maker decides when the care starts. And when I say decision maker, remember I'm talking about an agent, a medical power of attorney, a proxy, whatever your legal designation is in your state. When the person no longer qualifies for hospice, and there are lots of reasons someone might not qualify, hospice agencies are required to discharge them off the service. We're going to get into more details about discharges later on in the presentation. But only the patient or their medical power of attorney, the agent, can decide when to start hospice. And here's a little tidbit. The term that hospice agencies use for choosing to start hospice is election. You elect to start hospice. A few tips for this section. Hospice teams come into the care of a patient for typically a fairly short time. Caregivers have been with the patient for a long stretch. They are the experts in the care of that patient, that person. Sometimes there's not time to have in-depth conversations about end-of-life wishes. Accidents happen, emergencies happen, strokes, heart attack, brain injuries. When there's an urgent situations, caregivers have to make decisions based on what they know about their person, how the person lived their life, how they expressed love and faith, and how they made decisions. Not everyone has the luxury of time for these delicate conversations about death and dying. There are still ways for a caregiver, for you as a caregiver, to make good decisions and the right decisions for your person. These are not easy decisions, but you can definitely do it. All right, number 6, signs that it's time for hospice. And I will tell you, there are 2 slides for this one because there are a lot of signs that it might be time for hospice. The first thing is your healthcare team might be bringing up the topic. They might be using the terms serious illness or terminal prognosis, terminal diagnosis, or limited life expectancy. Hopefully they're using terms that are meaningful to you as a caregiver and more easily understood by someone who doesn't work inside healthcare. There might be frequent infections that are occurring, like bladder or respiratory infections, pneumonia, even sepsis. There might be more frequent visits to the ER or hospital stays that are more frequent or longer. You might notice a reduced appetite or weight loss, even if your person is taking in supplements like Boost or Ensure or Glucerna. Your person might also be having difficulty managing their own care, their activities of daily living, what we call ADLs, things like personal hygiene, bathroom habits, getting dressed appropriately, feeding himself or herself. Another sign that it might be time for hospice is if the treatments are becoming too difficult for the patient, or they're actually causing more problems than they solve, and the patient's ready to stop them. You might be told by the healthcare team that the treatment that the patient's receiving is no longer effective, that it's not working anymore. Your person might also say they no longer want to go to the hospital if something happens. Another sign that it's time for hospice is a decline in mental functioning, with your person becoming more drowsy, sleeping extended hours, increased agitation or confusion or anxiety, or increasingly forgetful. And of course, in this list, we have to include the worsening of symptoms of the primary illness, the biggest medical problem that your person has. If it's a respiratory illness, you might see increased shortness of breath. Mental confusion and agitation may be worsening in folks with Alzheimer's or dementias. Pain levels might be increasing for certain types of cancers. And people with cardiac disease may have increased shortness of breath, angina, chest pain, edema, or increased intolerance of any activity. There can be numerous clinical signs from the illness itself that indicate that hospice may be a good choice. Here are a couple of tips if you're seeing some of these signs and you're wondering about where to go from here with decisions about your person's care. I will tell you, it's always okay to ask about hospice, and it's never too early. You're just gaining information. It's important to educate yourself. And inside your system, your healthcare team, your friends, families, everybody that's in this caregiving village, there will be someone who is safe and trustworthy that you can talk with about hospice care. Okay, here's the question, the topic that nobody wants to bring up. This is maybe worse than the death and dying conversation is, who pays for hospice? How does it get paid? It's easy to talk about the wins and the whys of hospice, but it's really important to know what it's going to cost you. So in the United States, Medicare, Medicaid, depending on your state, covers the care, everything related to the main diagnosis, the terminal diagnosis, and the equipment and medications that are needed. There might be a 5% copay that the patient or family would be responsible for. If you have a Medicare Advantage plan, they can have different out-of-pocket costs, so you have to ask individually about your cost. Private insurance, hospice is covered according to the individual plans, and the VA covers hospice at 100%. There's no copay there. Excuse me. Okay, some tips about payment, about the payment part of hospice. Ask what's going to be covered before the service starts. Get it in writing, including information about medications and equipment. Excuse me. Be sure to get copies, keep copies of everything. Ask for paper copies that for documents that you sign digitally. You store it for yourself in a binder or folder, keep it all together where you can access it easily, because a lot of documents are done digitally these days with agencies, but they are required to let you know your financial responsibility, things that will not be covered in advance. They're required to do that. Okay, item number 8. Hospice can be discontinued if your person no longer qualifies. This is important to know. Hospice agencies are responsible for ensuring that every patient on their service qualifies for hospice care. Sometimes patients begin to thrive, they stabilize and improve, so they don't meet the criteria anymore. The hospice agency has to let you know in advance that the care is going to be discontinued. They call that a discharge notice. If you don't agree with the discharge decision, you can appeal it. Your hospice agency is required to give you instructions, furnish you with those instructions on how to file an appeal. And a little known fact is during that appeal, your hospice agency is required to continue providing care until that decision is received. Even a lot of hospice agencies don't know this. So you have the right to appeal, and they have to continue care until the decision is received. A tip about discharges: if your person's health status changes, they have a decline, something happens, you can request to be reassessed to see if they qualify for hospice and can be readmitted. Patients can be readmitted. Item number 9, this is an important one because there's a lot of misconception about how much time the hospice team members will spend with the patient and the caregivers. So here's what you need to know. Visits are made by the hospice team intermittently according to what's needed. There's no 24/7 staffing for a stable patient. The nurse is going to see the patient 1 to 2 times a week when the patient's stable. Those visits will increase if there are issues with symptoms or there's a change in condition. The nurse or a nurse will always be available by phone 24/7, weekends, holidays, after hours, and you can always reach a nurse by phone. Social worker and chaplain visits are usually 1 to 2 times a month. Again, additional visits are made when there's a need, a concern, a question, or a crisis. Aid visits are scheduled according to the person's needs. So for instance, somebody who just needs standby assist for a shower, they would have less frequent visits versus someone who is bedbound and has a catheter or is incontinent and needs a bed bath. They would have more frequent visits. Some tips about the visits: ask questions. Don't be afraid to repeat them. Ask about the schedule, see what you're entitled to, and what would warrant an extra visit if you needed it. If there's part of the care that's not going well or doesn't seem like a good fit, It's okay to make a request for a change in the staff, or even to make a complaint if you need to. The caregiver is the expert, remember, vital part of the care team. They know the patient better than anyone else. And most importantly, you have to remember that hospice never takes the place of the family caregiver. Caregivers, family, or facility staff provide most of the day-to-day care of a hospice patient. And finally, number 10, hospice care can be utilized for all end-stage diseases, not just cancer. So I will tell you that Alzheimer's disease and dementias are the top 2 most frequent hospice diagnoses in Medicare hospice patients, with COPD, respiratory illnesses, COPD specifically coming in at number 3, and heart failure coming in at number 5. I've got a link in the resource slide to the latest edition of a document called Facts and Figures. It comes from the National Alliance of Home Care, and it has all these different stats about hospice in the United States, Medicare utilized hospice, and it's data from 2022. It's really, really helpful. So just a few tips here. Learn what end stage means for your diagnosis, what it looks like for the diagnosis that your person is dealing with. Be proactive about talking to your healthcare team. Don't be afraid to look ahead. It's okay to ask questions and educate yourself. Research agencies where you live if you have that time. You know, if something happens suddenly, like a stroke or a heart attack, you might not have time to shop around for a hospice agency. But if you do have the luxury of time, it's a really good idea to talk to 2 or 3 of them in your community that provide service where your person lives. Now, when it comes to where your person lives, if your person lives in what we call a long-term care facility, a nursing home, it's important to ask what agencies that facility is contracted with. Because according to regulations, federal regs, hospice agencies have to have contracts with the nursing homes where they go in to see hospice patients. The facility where your person lives may not be contracted with the agency you're interested in, or they may not be contracted with the one that's already providing care for your person if your person is at home and they're needing to be moved to a different living environment. So ask the facility which agencies they have contracts with. Super important. And just a few bonus tips. I always like to give a little extra. When you're advocating for your person, be sure to advocate for yourself as well. Those end-of-life conversations that are so hard to have can help you make decisions later on. Do what's right for you and what's right for your person's care. Hospice isn't always a perfect fit or a good fit. You have to do what's right for you. And above all, remember that caregivers matter too. Caregivers matter. You matter too. So here are the resources I've got listed for you. Links to everything. Lots of resources there to help you. And I'll say thank you for your time, and let's go to a Q&A session. How can I help you? So Calvin, I'll turn it over to you.
Thanks, Helen. So yeah, let's get right into the Q&A. I see a lot of people have put questions in chat, so I'll definitely get to those. First off, we have a question in the Q&A. A listener wants to know, is hospice care given at home only? I live alone without a family and would need to go to a facility. And they would like to know, are there any in San Francisco? So I would add that, how would they look up, is there like a website to find out what the agencies are local to you?
That's a great question. I am not local in California, so I could not answer if there are some agencies specific in California, but I will tell you there is a website called Care Compare, and you can find hospice agencies there that are in your area. All you have to do is enter your city name in, and you can find all the agencies that service that area. And you can find like the star reviews and read demographics and get contact information for each of those agencies that service your area. Also, you asked if hospice agencies provide in other places besides the home. Absolutely. Assisted livings, personal care homes, long-term care facilities, nursing homes. Yes, multiple places. And they do want to help you find a caregiving system, because even if they take on a patient that doesn't have any family and lives alone, hospice still is unable to provide 24/7 care. So that's a really good question. Thank you.
Okay, and I guess as an add-on question, someone in chat wanted to know what questions should they be asking when they do research on different hospice agencies?
That's a great question too. I would start out with something as simple as, is the agency for profit versus nonprofit? Because for some people that's very meaningful and you want your agency to be in alignment with your values. So that's the first question. I would ask if their hospice medical director is hospice and palliative care certified. That makes a difference. Ask how many patients are in a caseload for their nurses and their chaplains and social workers. Because the more patients in a caseload, the less often a visit will be made to a stable patient. So ask about the caseload. If you need help with personal care, ask how often an aide would be out to help with the personal care. I think those are some good basic questions to start with.
Okay, thank you. We had another question actually for maybe the next 5 or 10 minutes. Would you be able to put it back to the previous slide, which had the list of resources?
Absolutely.
And then we'll make sure to end with the contact information. Okay, we have another listener who wanted to know, could you please elaborate on the respite care that is covered by Medicare and hospice?
Ooh, that's a good question. I really didn't dive into that. So there is inside the Medicare hospice benefit, there is a benefit that includes 5 days of covered respite care for a hospice patient. The way it is used is it is all about the caregiver needing relief. If they want to take a few days off, if they want to just have some rest, if they want to go to a family event, a wedding, etc., or if they need to have some sort of healthcare procedure done. The hospice agency will cover 5 days inside a Medicare certified facility. Most of the time, that is a long-term care facility, a nursing home. But it's the financial responsibility of the hospice. They coordinate that. They pay for the transportation, even if it's an ambulance transport, for the patient to go from home to the respite facility, and then they pay for the transport home. The nurse sets it all up. The hospice staff continues to see the patient while they're in the nursing home, but they have the 24/7 care because they're in a facility. And that's a great way for a caregiver to have some time away. They don't even have to have anything big going on. They can just do it because they need some rest. A question that goes along with that is, how often can you get respite care as a hospice caregiver? I will tell you that there is no regulation that says explicitly how often a hospice agency has to offer that. Most agencies will offer it once inside a cert period, which means every 90 or 60 days, because that's how it's set up. So when you're talking to an agency, that's another great question to ask. How often do you offer respite care services and where do you do it?
Thank you. Um, Someone wanted to know if there would be slides sent out to attendees. Yes, we can take care of that. We'll have the slides up and then we can also post a recording. So that's another question. They also want to know, let us see, sorry, just, okay. Can the questions that you're mentioning about the finding a hospice, choosing a hospice, do you have any resources or specific podcasts? They're wondering if they could have it in writing. So yeah, I guess, do you have any kind of resources on your end that you could point people to in terms of specifically looking, doing research into hospice? The questions to
Yes. Look at the podcast. theheartofhospice.com. Look at the Heart of Hospice podcast. There are resources in there about what I call hospice shopping. It can be a time-consuming process, but I think it's important if you have the time to do that in advance. But yes, there are some episodes of the podcast that talk about that. You can also look at the caringinfo.org website, which is a very broad, tons of resources, a big website, and there will be some information there about choosing a hospice agency. Great question.
Another listener wants to know, is palliative care covered through Medicare?
Palliative care as a specialty is not covered by Medicare. There's no payer source for it right now. But when you talk about a hospice patient, the palliative care is not a specific specialty. It's embedded in, it's part of the care we provide. But as a specialty, no, palliative care is not covered by Medicare.
Okay, thank you. We had another viewer want to know, they have a 92-year-old mother who has Alzheimer's, advanced case, it sounds like. Very limited ability to do the activities of daily living. Constant state of confusion, often has shortness of breath, and they're wondering, should they be considering hospice care for their mother?
I will tell you, it's really hard to give a judgment about that, but one of the main basic things we look for in hospice for someone with Alzheimer's or a type of dementia is no walking, no talking. So a vocabulary ability of 6 words or less, or verbalization that's not reality-based is part of the criteria. And if your person is up and walking, typically they don't qualify for hospice quite yet. But remember, you can always ask and have somebody come out and assess and have a conversation with you. You can always talk to a hospice agency to find out what the criteria is.
Okay, thank you. We've got, let's see, another question in the Q&A. Okay, do you have information on how to receive support for grief groups? I think they mean, I would imagine that's like a support group. That's what they're referring to.
Yes, I will tell you that bereavement care is provided by every hospice agency in the United States for up to 13 months after your person passes away. So there's grief support there. We talk a lot about grief on the podcast. You can find some grief support there as well. And go to caringinfo.org, ton of grief support. And I would also recommend BK Books. Barbara Carnes has a fantastic set of booklets that includes some resources on grief support. But look into your local community, your local hospice agencies for grief groups if you're looking for a support group.
Okay, thank you. You've mentioned that if at all possible, it's great to be able to do the research about hospice ahead of time and have those conversations. And you mentioned that you work a lot with kind of end of life situations. Do you have any tips for people who are looking to start these kind of end of life conversations, even if the person is, not necessarily at that stage, for either the person who is asking might be uncomfortable, or the person they're caring for they feel might be uncomfortable, or they themselves are perhaps feel uncomfortable bringing this up?
Oh, this is a really hard topic, right? So the first thing I would tell you is take a deep breath. Whether you are the person with an illness that wants to have the conversation, or you need to talk to someone about their health status and their wishes, find a moment that feels comfortable. Go for a walk. If you have something to hold, to do, going for a drive in the car is a great place to start a conversation like that. Over a cup of coffee is a great place to start a conversation. There are a lot of tools out there. There are games that are a little bit lighter hearted. There are also a ton of resources from the Conversation Project, and I believe it's the conversationproject.org. And they have a ton of conversation starting resources that are free, and they come in multiple languages, so you can find something that is suitable for what you want to talk about and how you'd like to go about it. So look for those resources. Look for those resources.
Okay, thank you. Okay, so yeah, someone mentioned another resource on that is Five Wishes Advanced Directives. That's in the chat, fivewishes.org.
Yes.
Yeah, but
And
another.
just as an FYI, Calvin, Five Wishes, it's a fantastic document. It's fairly simple, and it's legally recognized in every state in the United States as an advanced directive. As long as it's documented correctly according to what that state requires. But it's a fairly simple form, and it's got some reflective and some practical healthcare stuff on it. So Five Wishes is a really good document to use.
Great. Okay, well, thank you very much. That was a great resource. Thanks for bringing it into the chat. We had another person want to know about Kaiser. Did it get deleted? Well, I can't find it right now, but I think as I remember what they're asking, they wanted to know what the relationship between Kaiser and hospice is. I guess maybe is it common for larger health systems to provide their own like hospice services, perhaps?
I can't speak to Kaiser specifically, but it's not unusual for large systems to have hospice agencies as one of their business lines. You know, a hospital system may also have home health and therapy organizations, and they may also have hospice agencies as well.
Okay,
That's not unusual.
okay. Um, okay, another we have another question in the Q&A. They wanted to know, can you talk a little bit about treating other conditions while on a hospice other than the primary hospice diagnosis?
Okay, that's a really good question. It can get complicated, and it really is determined on a case-by-case basis. So what Medicare says is virtually all of the care of a hospice patient is the responsibility of the hospice agency. So let's take something simple that's fairly common, like a wound. Wound care should be managed by the hospice agency. They shouldn't get an outside company necessarily to manage it unless it's outside of the skill set of the nursing team that they have. So for bigger things that are unrelated, so dialysis is one. Say you have a patient that has lung cancer, but they also have end-stage renal failure, and they receive dialysis 3 days a week. That is something that would not be managed by the hospice agency, nor would it be covered by the hospice benefit. The traditional Medicare insurance would cover that, and the patient could still seek that particular treatment. But that is a conversation to have with your particular hospice agency prior to care starting. Prior to care starting. That's a very good question. And I would say the biggest hint or the biggest tip I would give to you about that is get all the details from the hospice agency that you'd like to use before the care starts. So you're very clear on what you can and cannot do without ending up receiving a big medical bill that you have to be responsible for yourself.
Okay, thanks. We have another question in the Q&A. They want to know, can you treat something at the hospital while on hospice?
The answer to that is yes. For instance, a patient with COPD falls and has a fractured hip, breaks a hip. Yes, they absolutely can go and get that treated. We also treat infections. Being on hospice care doesn't mean that we ignore other things that are going on. We treat skin tears, we treat wounds, we treat infections. So that should never be an impediment to receiving end-of-life care for palliation and comfort and quality of life, because you can get those other things treated. There's nothing that's going to restrict you. And if you choose, to treat whatever it is, and your hospice agency is telling you you can't, as a decision maker, you can always make the decision to stop the hospice care, revert back to the traditional Medicare, and get treated freely the way you would like.
Okay, great. I do have a clarification on that Kaiser question. So they actually wanted to know. So it looks like the Kaiser's, their healthcare provider. They want to know in terms of the primary care physician, which this case would be like the Kaiser physician or whatever big medical system. Who kind of has the final say in care? Is it the primary care physician? Is it the hospice physician? Kind of, yeah. I guess what is the how are decisions, big decisions being made between the two of those practitioners?
Okay. So if I understand the question, if the primary care physician stays on as what we called an attending physician, they work side by side in conjunction with the hospice medical director. So
Okay.
the attending physician would make the decision, unless for some reason they're not available or they don't answer quickly enough, the hospice staff would go to the medical director.
Okay, so it'd still be if the primary care doctor stays on as the attending, they would still kind of be the primary. Everything would still go through them.
Yes, I will say that many primary care doctors choose not to continue on with their patients when they move into hospice care. For one thing, it's not their area. It's not their area of expertise. And the demands for time and responses, sometimes with hospice patients, are very quickly. We need an answer very quickly. And hospice medical directors, their systems are set up to communicate very quickly with hospice teams, where an attending physician might not communicate back as quickly.
Okay, thank you. That's great. That makes a lot of sense. We have another listener who wanted to know, can you advise in general, are hospice agencies using death doulas? And I guess could you kind of explain that for people who are unfamiliar with those? More frequently as part of overall care. So again, the question is, can you advise in general, are hospice agencies using death doulas more frequently as part of overall care?
Oh, I love this question because we didn't talk about doulas at all. So in the United States, well, actually globally, there's a movement to incorporate end-of-life or death doulas into the care of folks that are dying. End-of-life doulas are non-clinical companions who are very knowledgeable about death and the dying process. They provide support, education, grief support. They can have advanced care plan conversations, but they are not licensed or registered in any form. There is training across the United States, but it's not standardized. So it's not regulated. So what I see right now is hospice agencies may very rarely incorporate the care of a doula as part of the team, but that's unusual. Sometimes doulas are utilized as volunteers, but they are not technically using their doula skills. Because again, there's no regulation and no standardized education. There's no licensing organization for doulas. You can hire a doula privately out of pocket, which I think is wonderful because it's a great supplement. It's not an either or. If you have hospice care, you should also have an end-of-life doula, which I think would be amazing. But if you have a doula, you would still need the hospice care for the medications and the after hours and all the additional disciplines that come with the hospice team. I think doulas are underutilized, but they are really, really a wonderful part of end-of-life care, and they can be a great asset to the care of someone who's terminally ill. That's a great question.
Thanks. Here's a question I got on the registration form. Someone wanted to know, just kind of based on your hospice experience, do you find generally people, after the whole experience has happened, they found that they started the process at the right time, or they maybe should have started it early or later? how do you find people after everything's happened? Do they in terms of timing, do they feel like they've started at an appropriate time, or maybe they should have started a little earlier, maybe a little later, things like that?
What we hear most of the time is people think they started too late. There's a very large percentage of hospice patients that are only on service for about 2 weeks. And hospice is for much earlier than that. You don't have to be actively dying on death's doorstep to receive hospice care. In fact, the benefits of the whole team are much more widely accessed, and patients and families get so much more comfortable with the hospice care if it's initiated early. In my experience, that is a common regret among family caregivers. I wish we had started this sooner. That's very common.
Thank you. Sorry, someone wanted to know about the death doula spelling, so I had to quickly look it up. Okay, it looks like we have time for one last question. Would you mind putting it back to your contact information if anyone needs to get in contact with you? Great.
Will do.
I'm just looking to see if make sure we answered everyone's questions. I believe we did. Um, so I guess this maybe this is a little bit too broad, but in terms of this presentation, are there maybe like one or two things you'd like people to take away of to remember to kind of have in the back of their head? Because it's difficult to, to remember everything, and caregivers are so busy. Is there maybe one or two main points from today that you'd like people to take away?
Absolutely. I would remind every caregiver that you are the expert. You are vital. We need you. Healthcare teams rely on you. You're the historian, the record keeper, the memory keeper, the negotiator, the translator. You are the expert in your person, in their lives and who they were. And so your value as a caregiver is priceless. Priceless. I would also say be brave when it comes to having those conversations, the end of life conversations. Get your hospice team to help you. They're used to having those conversations, and they can help you find a resource, a way to do it, and the questions to bring up so that you can be comfortable. But just have courage when it comes to that. And I would also say, as a caregiver, to give yourself the grace that you would offer to your best friend. Don't be harder on yourself than you would be to anyone else. I'm a caregiver for my mom, 92, and she has dementia, along with my two siblings. And I have learned that how I talk to myself about who I am as a caregiver is very important, because I would encourage someone else. So when you talk to yourself as a caregiver, give yourself every benefit, every bit of the care, and every bit of the grace that you would give to someone else.
Thanks so much, Helen. It looks like that's about all the time we have for today. I am going to launch a quick evaluation poll, and we'd certainly love if you could let us know how we did. Again, thanks everyone for joining us today. The Family Caregiver Alliance webinars are free. We do them every month. Next month, we're going to be talking disaster planning, disaster preparation, both in English and Spanish. And you can find out more about our webinars at our website, caregiver.org. So thanks again for joining us and spending your time with us. And thank you, Helen, for sharing your expertise with us. We love to have you on, so we really appreciate that you're able to come on again.
My pleasure. Thank you so much, Calvin, and thank you to everybody who's watching and will watch. I appreciate you.
Thanks. So again, thanks everyone. Take care, and we hope to see you next month. I will stay on for a minute or two. So if you have time to fill out the poll, we'd love that. I know Helen's super busy, but I will definitely be on the line. Yeah, I'll stay on the line, and if you have any questions, you can keep on chatting them, asking in the chat. If they're Helen specific, I can always forward them to her, or you can see her information on the the slide. But so yeah, thanks again. I'll leave the line open for a little bit longer, probably for about 5-10 minutes for anyone who's willing and able to fill out the evaluation. So thank you.
Thanks, Calvin.
Thanks, Helen.